Welcome everybody to GoLocal Live. I'm Josh Fenton, CEO and co-founder. A little news before we go to Dr. Fine. First up, an in-depth look at the complexity of the Department of Labor and Training's very, very outdated technology infrastructure. Take a look at that on the site. A little scheduling. This morning at 10:30, we had Rebecca Cotto da Silva Skyping in from Bolzano, Italy again, giving an update and almost a harrowing experience of taking her daughter to the dentist. What needed to be done to just go and take her daughter to have a tooth removed during the lockdown in Italy that's ongoing. And then at 1 o'clock after Dr. Fine, Governor Raimondo will have a 1 o'clock briefing. Again, she is not allowing the public to hear reporters' questions and responses. That's all done through third-party PR people and then offline. So we'll continue to press her on changing that policy. That's a very unusual policy. Cannot find any other governor who's doing that. And obviously the president's not doing that. I think he likes the exchange with the reporters across the country. Dr. Fine, thanks so much for joining us.
Thanks, Josh. Nice to be here.
Okay, let's go to the numbers. U.S. is now number 2, sadly, in deaths, trailing only Italy. Take us through all the other numbers.
Sure. We have 1.6 million cases worldwide, 365,000 recoveries, 468,000 cases in the United States. Our increase, we've been kind of flat in terms of increasing. That's good news. But again, these numbers are a function of testing, not necessarily a function of disease. World deaths and U.S. deaths are putting us way too high. I actually realized I don't have today's death numbers, fortunately or unfortunately, but I'll have those for Monday.
World deaths, I believe, are 97,000, as I think you predicted. We are likely to go over 100,000 worldwide deaths tomorrow. And U.S. deaths, we may be at 20,000 by the end of the weekend. I believe we're at 17,000 now. So,
yeah, we're going up 2,000 to 3,000 a day. Rhode Island deaths are 7.
Yes, 43 total, I believe, in Rhode Island.
Total, 7 in 24 hours.
Yep.
And 160 people in the hospital, 45 people in the ICU. The very good news for Rhode Island is that our hospital numbers and ICU numbers, while increasing, are increasing doubling over 5 or 6 days, not doubling faster than that. We're going to see increases, but it's the rate of increase that we're seeing as reasonably controlled, and that's good news because it gives Rhode Island time to be ready for the peak when it comes, which now looks like it's in late April.
Massachusetts crossed over the 500 death mark yesterday. While they are 10 times the death rate, they're only 6.2% larger in population, 6.2 times larger than Rhode Island's population. Concerning numbers coming out of the Commonwealth.
Absolutely. And, you're going to see these kind of increases, I'm afraid, in places that are densely populated and that haven't been able to lock down their populations most effectively.
Nursing homes continue. We had a long conversation about the dangers of nursing homes and the much needed upgraded strategies to take on these nursing homes. Do you have any updates on that?
I do not. I believe that there are a couple of nursing homes that are really struggling with staffing, and I'm pretty sure that my colleagues at the Department of Health are working hard to help them sort that out.
I believe it was in Detroit, one nursing home had to be closed because the staff would not go to work. Literally, the staff boycotted because of the amount of contamination in that facility.
I'm hearing real commitment on the part of staffs to get to work, but once somebody is positive or needs to be in isolation, they can only do what they can do, and it's a real challenge for small nursing homes. I don't know for sure what our breakdown is in terms of size, but any nursing home less than 50 or 60 beds has a very thin staff by definition. They just don't have enough depth to be able to cover losing 20 or 30 or 40% of their staff. Bigger nursing homes, you can stretch it in different ways, but the small ones are going to have the biggest challenge, particularly if they see substantial numbers of their population getting this disease, because that means they actually have to segregate their population and segregate their staff. And basically, it doesn't quite double the staff requirements, but it becomes close to it. It's a real challenge for folks who have these family nursing homes that have worked for many years to keep things going, to keep them personal and small, but it's going to be a challenge for them to operate in the course of the next couple of weeks, I fear.
Dr. Fine, we're seeing disturbing numbers at different parts of the country. In Detroit, almost 900 healthcare workers in Detroit proper have tested positive. We know that in Rhode Island through Wednesday, I haven't seen updated numbers, but through Wednesday, about a third of those who tested positive, of those who have been tested, were healthcare workers testing positive. Any indications of any improvements in strategies here, or are we going to continue to see that trend across the country and here in Rhode Island?
This is a real challenge. There's sort of late-breaking research that looks at how easily the virus spreads. And it's more of a challenge than I thought it was. The classic difficult virus to contain is actually measles, which actually lives in the air, not necessarily as respiratory droplets, but even as individual particles in the air for a number of hours after somebody who's infected has been there. There's some research done on people who came off some of the cruise ships and were isolated that makes it look like this virus gets into the air and spreads more than 6 feet, excuse me, relatively easily. And that's going to be daunting as we try to sort this out and try to protect healthcare workers, because it's just a hard virus to get on top of once it's present.
Doctor, the president's making noise about opening up the economy next month, meaning May. That seems extremely premature based on the number of folks who have cycled through, either by test or by implication of been sick and worked their way through. We simply are at 1% data in the best of states, and at some states we're sub a third of a percentage of understanding what the implications are. Is that good thinking? Everyone is frustrated at the stalemate on the economy and the lack of work, but are we just going to continue to keep the health crisis going if we try and restart too early?
Well, we could, and part of the challenge, I think, is to build the infrastructure to take care of people with this disease. What I haven't seen is a Marshall Plan or a WPA to build the facilities we need so there are enough ICU beds and enough ventilators, because I don't think, and enough isolation opportunities. We haven't talked much recently about moving people into isolation, but I'm pretty sure that folks who live in densely populated living environments where you have 8 people in one house using one toilet, I think those are the environments where we need to pull out somebody who's sick and let them recover in an isolation hospital or environment. We got to have those in place as well before we can effectively open the economy without, having it shut down again from another outbreak. So, what I'd love to see the president do is really kind of come in with a plan to build the facilities we need to effectively take care of people when they get sick. And then when they're put together, there are a lot of people out of work. I'd love to see them put to work building these facilities. Then when all that stuff is put together, then I think we can have more rational conversations about opening the economy.
In certain parts of the country, they've been out front. It's actually a majority of the country out front in reporting cases tied to race, and the numbers are quite disturbing in Louisiana, in Michigan, in New York. In Rhode Island, we still are unable to report cases based on race. That seems fairly outrageous that that is not something that the demographers can be able to add in to the reporting structure. That's been asked for more than a week. What's the problem there? Do you have any insights?
I have no insight into the problem other than this is a moving target and moving fast, and what we want the Department of Health to be doing is working on how to fix the problem, and maybe studying it a little later. That said, one would assume that we will see the same kind of racial and ethnic disparities in terms of hospitalizations and deaths that they're seeing in Chicago and Detroit. In Chicago, I think the number is 70% of their deaths are people of color, where 30% of the population are people of color. But, what this is doing, Josh, is exposing some underlying serious inequalities that exist in the United States. I mean, the reason more people are dying isn't because the disease discriminates in some way. The reason more people are dying is that the underlying health of people of color is not as good, and we have lots of evidence of that because of generations of historical inequality and discrimination. That has impacts on people's health and well-being, and that's what this is unroofing in a very painful way. When there are disparities in outcome, some of it may be disparities in access, but a bunch of it is disparity in underlying health, and that's what we ought to carry forward into the future and commit ourselves to fix, so we don't see the kind of disparities in death that we're going to see as a result of the differences in underlying health.
I'm going to raise the point, though, that many minority leaders are saying is this can't wait till afterwards. Listen, if we've identified that certain areas, because of demography, are going to be more susceptible to death and permanent injury, don't we need to have that data right here and right now when we only have 11,000 tests completed? Trying to then pull that data after the fact a year from now, when there's 200,000 people tested, doesn't have the same potential impact at putting resources where we need to try and help isolate folks who are most at risk.
The people who are saying that from those communities are exactly right, but I think we can assume that those disparities are going to exist and work today to start to address them. To really develop concentrated efforts to have respiratory clinics and testing in underserved communities, and make sure we have options for people who are living in congested housing to go into isolation. People of means, when they get sick, sometimes leave their house and check into a hotel. Not everybody can do that. When respiratory clinics first opened, there were 4 in East Greenwich and none at that moment in Providence, Pawtucket, or Central Falls. That's fixed a little bit, but the density of services needs to at least match, from underserved places to better served places, and probably should be many, many, many times more intense.
Well, and our testing facilities demand you have a car. Poor folks of color who live in Providence, Pawtucket, Central Falls right now can't get to a testing facility unless they have access to a car, because there's no other option there.
Well, I think there are options for folks with Medicaid, but not for folks without insurance. And that's particularly concerning for people who are undocumented. And those numbers are real. For undocumented people, there are lots of counter incentives to make sure that, to keep people from saying that they're sick and from getting tested and from getting isolated if they're positive. or for staying in isolation even if they're sick. Most of these are folks who don't have access to Medicare or Medicaid, or none of them have access to Medicare or Medicaid, don't have access to insurance whatsoever, have to keep working because there's no other way to keep their families fed. They're not going to get the $600 extra a week that people who are applying for unemployment can get. So they've kind of got to keep working. That's a real trap. And I'm not sure I can think out exactly how we're going to address that. But if we don't put focused attention to it, if we have 50,000 undocumented Rhode Islanders, and I've heard the number is estimated between 25 and 50,000, but if we have 50,000 undocumented Rhode Islanders, that means we could have 5,000 undocumented people in hospitals just based on that number. 5,000 people in hospitals, will fill the hospitals. So we could do a great job in East Greenwich and really reduce the number of people who are in the hospital at once. But if we don't do that same great job in parts of Cranston and Providence and North Providence and Pawtucket and Central Falls, we're going to end up right back at the same place.
Yeah, absolutely. And listen, those restaurants in East Greenwich on Main Street have folks sometimes, who are working in those kitchens, who are keeping those restaurants going, who are exactly in that population.
That's exactly right. Working in kitchens, working as cleaners, working anyway, working as landscapers. People are doing everything they can to keep body and soul together. But this disease is, as I've said before, a fierce taskmaster and is going to hit everyone and infect everyone. The challenge is how to reduce the intensity of the infection and prevent everyone from getting infected at once.
Dr. Fine, before we go, what else do folks need to know going into the weekend?
Just keep doing what you're doing. Rhode Island is doing fantastically. We can and must do better. And we can and must take care of our most vulnerable population and bring to it everything we can to keep this to keep this disease at bay as long as we possibly can.
Dr. Michael Fine, former director of Rhode Island Department of Health, thank you again, as always, for joining us and giving us the most up-to-date insights. For everyone else, Governor Raimondo will appear at 1 p.m. live stream on GoLocal. Stay tuned for some other updates. Also, look for some insights into some financial issues that are now cropping up on the state and on the cities around the state of Rhode Island. Very complex issues that are emerging. Thanks, everyone, for tuning in. We'll see you back later.
Thanks, Josh. Have a good weekend.
Thank you.